On behalf of Inovocare E-Academy and Inovocare Health Stop Solution, I welcome you all. And it is really honor for us to have two experts in the field of pulmonology, Dr. Susmita Roychowdhury and Dr. Raja Dhar. They are all not only famous in the field of pharmacology, national or internationally, they are now the frontline warrior.
You mean pulmonology, not pharmacology, pulmonology.
Yeah, pulmonology.
Yeah.
So now during this COVID, our war against COVID, they are the frontline warrior and they are leading from the front actually. So Dr. Susmita Roychowdhury is now the director of Fortis Hospital, Anandapur, Kolkata, in the pulmonology and Department of Chest and Sleep Medicine. She had done her MD in Respiratory Medicine, MRCP, European Diploma in Adult Respiratory Medicine. So it is really honored to have you, madam. Welcome in this e-podium. And we have Dr. Raja Dhar, who had done MD in Respiratory Medicine, MRCP, European Diploma in Adult Respiratory Medicine, MSc in Evidence-Based Medicine. So, sir is now Director and Head of Pulmonology in CMRI Hospital. So, welcome you, sir. And it is always a great honor to have you with us, sir. So, the first topic for today is on update in asthma management and specifically the challenges in adherence. Now, without any delay, I welcome Dr. Raja Dhar to deliver on this topic. Welcome you, sir.
Thank you, Dr. Absolute honor to be with all of you. These are difficult times for all of us. And I'm pleased to see quite a few people logged in to listen to this already. It's been a while since I've done a non-COVID talk. I have not actually managed to prepare a formal presentation for this talk because of the lack of time and because of what's going on around. What I will do is to use the GINA slides, which is the Global Initiative in Asthma slides, and I will talk to you on the basis of these slides. These are for the purpose of teaching and dissemination, and hence there is no conflict of interest in using these slides for teaching purposes. So let's start off by talking about the burden of asthma. So the reason we talk about airways disease, and Dr. Roychowdhury is going to speak about COPD next, but in my ambit, the reason we talk about asthma is that it's one of the most common chronic diseases with about 30 million affected in 300 million affected individuals worldwide. The prevalence is increasing, especially in the developing world. So in Asia, China and India in particular, in Africa, and in certain parts of Western Europe, the prevalence of this disease is gradually going up, especially in case of children. Asthma causes a lot of morbidity. In fact, between the two diseases, asthma causes more of morbidity, thankfully less of mortality. And because of the morbidity, the expenditure on asthma, as far as healthcare is concerned, is significant. So this is from GINA, and it looks at the GINA assembly. So what I'm going to talk about encompasses most countries of the world. And you can see India at the left bottom corner, even though it probably merits a more prominent place in this entire globe because we have the largest mortality from asthma throughout the world today. So I start off talking about definition and diagnosis. We know asthma is common. It's a serious chronic disease. And later on in the disease course, the disease can be controlled but not cured. You would notice I've changed what's written on the text on the GINA slide. And that's because asthma becomes a chronic disease when airway remodeling sets in. When there's only bronchial hyperresponsiveness, as is the case early on in the disease, and if you manage to start these patients on inhaled corticosteroids early enough, you might actually prevent airway remodeling. And there is a small cohort of patients with asthma where the disease might actually be curable, but we'll talk more about this as we go along. The symptoms of asthma are known to all of you. So the wheezing, the breathlessness, the chest tightness, and very important, the cough, which is often the only manifested symptom. They vary over time in their occurrence, frequency, and intensity. And a symptom like cough might be the only manifestation of asthma, a condition which is described aptly as cough variant asthma. And again, we'll talk about this as we go along. The reason you have these symptoms, i.e. the wheezing, the shortness of breath, and chest tightness, is because of the narrowing of the airways, the bronchoconstriction, the airway remodeling in the form of airway wall thickening, and the increased mucus. And I want you to hold on to this simple 3 points: the airway narrowing or bronchoconstriction, the airway wall thickening, and the increased mucus, because the pharmacotherapy that we use for this condition are aimed to addressing these 3 issues. And again, we'll come back to this when we talk about treatment. Asthma is a disease of triggers, and these triggers are different for different individuals. We did a study called the AP-AIM study, the Asia Pacific Asthma Insights into Management study, which looked at 8 different countries in Asia. And we found that in India, the commonest triggers seem to be viral infection, change of temperature, especially cold, chilled drinks, etc., and the allergens in the form of pollen, etc. The triggers that you see on there, the tobacco smoke, the exercise, the stress, etc., are also triggers in India, but they come lower down in the algorithm when you think about triggers particular to our country. And this is important when you treat asthma in specific parts of the world or specific parts of a country. When asthma is well controlled, the patients should not have any symptoms. So if you look at the GINA definition of asthma control, you should not have any symptoms, and the symptoms are enlisted on there. So no daytime or nighttime troublesome symptoms in the form of cough or breathlessness, little or no use of reliever medication, and we'll come back to what that is. You should have a productive, physically active life, a near normal or normal lung function, and the aim would be to avoid any exacerbations, which are the cause of mortality and most of the morbidity that is associated with this disease. So that's the current GINA definition of asthma, which is calls it a heterogeneous disease with chronic airway inflammation. The symptoms that we have described a little while ago, the fact that these symptoms vary over time and intensity, and they result in variable expiratory airflow limitation. So I want you to concentrate on these separate terminologies because they are key to what we're going to discuss today. The fact that it's a heterogeneous disease, this chronic airway inflammation, the symptoms are enumerated on there, but the symptoms are variable. There is diurnal and there is seasonal variation. And the fact that these symptoms are caused by variable expiratory limitation. The diagnosis of asthma is based on history. So the history is important in the diagnosis of asthma. The spirometry adds on to the diagnosis of asthma. However, spirometry is not compulsory in making a diagnosis of asthma. And this is important, especially in today's day and age, when spirometries are difficult given the risk of aerosol generation, which is associated with the COVID pandemic that we are all undergoing today. You have to document evidence for diagnosis in the patient's notes. So the prescription should have the diagnosis written. It should not have vague terminologies like acute bronchitis or cough, wheezy cough, or chronic bronchitis, etc. It should spell out that asthma is the underlying diagnosis and the fact that treatment has been started on XYZ date if you are the person who's initiating treatment. We've talked about airway inflammation and airway hyperresponsiveness. However, the history, like we said, is sufficient and you don't need to document that in the form of spirometry. So this is the simple algorithm from GINA, which talks about the diagnosis. So are the symptoms that the patient presents with typical of asthma? You base that on a typical history, examination findings, ideally do a spirometry, or if that's not possible, you do look at peak flowmetry over a period of 2 weeks. So I'll repeat that: peak flowmetry over a period of 2 weeks. And you want to look at diurnal variability. And if these features, so the history and examination findings plus spirometry or peak flow variability through the day, if these three match up, and you have clinched a diagnosis of asthma. Once you've done that, you would want to treat the disease. If at any point of time you doubt that the history is not consistent with asthma, you look for asthma mimics or differential diagnosis of asthma. If you find that the spirometry is inconclusive or normal, you might want to repeat the spirometry or the peak flow recordings on a different occasion. And if the spirometry is not possible, like we discussed a little while ago, you might want to put these patients on a trial of therapy based on the history that you've taken for these patients. And like we said at each step, do think of alternative diagnosis. Increased probability of asthma is based on certain factors. Any one of the symptoms of wheeze, shortness of breath, cough, and chest tightness, the fact that symptoms are worse at night, they vary over time and intensity, and that there should be a trigger. These sound simple, but remember, any one of these increases your probability of having asthma, and it should trigger the thought of asthma in your mind. What makes asthma unlikely? If you have a cough without any symptoms even of the upper airway, so no allergic rhinitis, etc., you can still have a diagnosis of cough variant asthma, but that's unlikely. Usually you would have some allergic upper airway symptoms along with the cough to get to the diagnosis. If there's lots of sputum production, there should at least be an overlap with a condition like bronchiectasis. If you have very severe breathlessness, the patient says that due to the breathlessness, they get dizzy, lightheaded, they have tingling and numbness of fingers around the mouth. You think that the patient is having panic attacks and hyperventilating. Chest pain is unusual in asthma unless you're coughing a lot and you've pulled a muscle around the ribs. That might cause chest pain, but chest pain de novo is unusual in patients with asthma, and exercise-induced dyspnea with a noisy stridor, which is more from the upper airway, is unusual in asthma and is actually a medical emergency. I won't talk a lot about spirometry and the diagnosis of asthma, but suffice to say that you have to confirm airflow limitation to support your clinical diagnosis of asthma, which is airflow obstruction defined as an FEV1 FVC ratio of less than 70%, and the fact that you categorize the degree of severity of obstruction based on the FEV1. In case of children, the ratio has to be less than 70%, that less than 90%. There's emerging evidence that the 70% cutoff is fallacious and it should be 75%, but that's emerging evidence. As of today, you would call less than 70% as evidence of obstruction. We talked about the variation of lung function and the fact that in healthy individuals, there's also a small variability between morning and evening peak flowmetry. However, this variability is much greater, to the tune of more than 50%, often 20% when you do this in asthma. So if you do a morning peak flow recording, the recording would be 15 to 20% lower in the morning as compared to what it is in the evening. A variability of less than 10% is something that you would expect normally. If you're doing spirometry and you're doing bronchial challenge testing, so bronchial hyperresponsiveness testing with salbutamol or levosalbutamol, you have to have a 200 ml and a 12% increase in FEV1 post bronchodilator. So it is more than 200 ml and greater than 12% rather than one or the other. The other factor which would support your diagnosis of asthma would be if there is a significant improvement, and Gina quotes a number of more than 400 ml between a recording done 1 month before, initiating treatment, and then having an improvement of more than 400 ml in that 1 month period with the treatment which is recommended and which we'll discuss in a few moments' time. If the initial testing is negative and the patient is symptomatic, you would want to repeat a test in these individuals. This especially is true in the young and in the elderly. I said I wouldn't talk about spirometry, but just very briefly, that's the typical spirometric recording. So you see two types of graph there. You see the time plotted against lung volumes, and then you see the flow plotted against volume. So that's the flow volume loop. And the greater the concavity, I hope you can see my cursor. So greater the concavity in this loop, the greater the degree of obstruction. And then you see the red line and the blue line. The red line is before giving the levosalbutamol. The blue line is after giving the levosalbutamol. And post bronchodilator, we said more than 200 ml and more than 12% clinches a diagnosis of asthma. If you're doing a physical examination on a patient with asthma when the patient is stable, it's often normal. However, if the patient is uncontrolled asthma or is in the middle of an exacerbation, you would hear wheeze. And here are just a few differentials. I have reduced the list that Gina gives, which is a very long, exhaustive list. These are some of the conditions which are also producing wheeze in individuals. So respiratory infections, COPD, upper airway dysfunction. Sometimes it's difficult to distinguish between stridor and wheeze, and that's why that goes in there. Endobronchial obstruction and foreign body. And when you have very severe bronchoconstriction, the airways are closed. You might have a silent chest. There's hardly any air entry. And that indicates a severe obstruction where the patient will be liable to get worse quite quickly. So when you talk about assessment of asthma, there are two domains that you talk about. One is assessment of control over a 4-week period. And the second is looking at treatment issues. And this is what Dr. Santanu Tripathi wanted me to specifically look at. So address things like inhaler technique and adherence. Talk to your patients about perceived side effects. There's a lot of thinking about inhaled drugs causing addiction. There is a lot of thought process about inhaled steroids causing side effects. And it's our responsibility as physicians, as respiratory physicians, or any physician for that matter, to try and dispel these doubts and myths. Only then is the patient going to be adherent to the treatment that you offer to these individuals. Does the patient have a written action plan? And I'll briefly mention the written action plan in a few minutes. And what's the patient's attitude and goals for asthma? So often patients have a very low esteem about asthma control. They feel a little bit of cough, a little bit of wheezing, breathlessness, waking up at night once in a while are things which happen in a routine, mundane daily life, and it's what is to be expected. And hence it's your responsibility to elevate the expectation from asthma control. The symptoms should be perfectly controlled and the patient should be completely asymptomatic if the physician is treating the disease right. The other important factor is the comorbidities. So often asthma coexists with certain comorbidities. You know about the one airway theory, the fact that starting from the nostrils, the upper airway, and then the lower airway, there is inflammation, and hence the upper airway, this chronic rhinosinusitis or allergic rhinitis, and allergy of the lower airway manifests in the way of asthma. So unless you treat the rhinosinusitis, you're not going to control the asthma. The same stands true about reflux disease, so gastroesophageal reflux disease, obesity, obstructive sleep apnea, depression, anxiety, etc. And unless you address the comorbidities, even perfect treatment of the asthma is not going to control the asthma symptoms, because these diseases are interwoven with each other, they're interrelated, and the comorbidities need to be controlled if the disease is to be controlled. As a part of your OPD consults for asthma, this is the very simple GINA statement looking at how well or how poorly asthma is controlled. So there's 4 questions that you need to ask your patient with asthma. Are there daytime asthma symptoms more than twice a week? Does the patient wake up at night due to asthma? Do they need reliever medications more than twice a week? And is there any activity limitation due to asthma? So 4 questions, very important to remember. This is something you can do in your day-to-day practice. You should do in your day-to-day practice. Daytime symptoms more than twice a week, nighttime waking due to asthma, reliever use more than twice a week, and any activity limitation due to asthma. If all the answers to these is no, then the asthma is well controlled. If it's 1 to 2, then it's partly controlled. If it's yes to 3 or 4, then it's uncontrolled disease. And this questionnaire has remained the same since the inception of GINA, which proves that even though it's a simple tool, it's a robust tool to tell you whether the disease is well controlled or not. So risk factors for poor asthma outcome, you have to assess the patient regularly. So GINA recommends that you see the patient back again in 2 to 4 weeks time, and then quarterly. And then after a year, you can see the patient every 6 months. And you make sure during these times, you look at peak flow charts. If you asked your patient to do that, you measure the FEV1 once a year. You assess the patient for exacerbations. You make sure that the patient is not having airway remodeling with fixed airflow obstruction, and you explore medication side effect. The other thing we have not mentioned here but talked about before is talking about compliance and adherence and making sure that you dispel the myths about about management of asthma with inhalers, inhaled corticosteroids, and such like. Often patients with asthma would stop treatment when they're asymptomatic. And this is again something which you as physicians, me as a physician, need to establish that asthma treatment should be regular and it should be long-term. These are risk factors for asthma exacerbation. These are factors which would tell you if you ask the question on the first visit, and if the patient has had an asthma diagnosis for a while, these are factors which will predict the risk factors for exacerbation. So has the patient ever been intubated for asthma, been on a ventilator? Does the patient have uncontrolled asthma symptoms? Is there more than one exacerbation in the last 12 months? Does the patient have low FEV1? Is the inhaler technique incorrect? Is the patient a smoker? And that's very damaging. Again, something that's a responsibility on us to counsel patients about, especially in asthmatics, but across the board in any patient who comes to you. And then the fact that obesity, pregnancy, and blood eosinophilia are factors you need to think about. And maybe we can discuss in question answers a little bit later, but those are factors that you need to think about in every individual patient who comes to you with asthma. So these are factors. So if you're obese, at the time of pregnancy, the exacerbations are variable. And if you have high blood eosinophil counts, your chances of exacerbating is going to be higher. And which are the patients who develop airway remodeling early? Which are the ones where there's fixed airflow limitation? Patients where you're not giving them inhaled corticosteroids, smokers, occupational exposures. So bakers, for instance, people who are exposed to smoke, construction business, etc. So all these occupations. Patients who are mucus hypersecretors. So your patient who have chronic bronchitis-like symptoms, maybe overlap with bronchiectasis, for instance, are ones who have fixed airflow obstruction, and blood eosinophilia is also, along with being a predictor for exacerbation, also a predictor of fixed airflow limitation. And you shouldn't give your patients long-term oral corticosteroids. That is probably the only side effect that I need to mention when we talk about side effects of medications in asthma. So we spoke about lung function, so I'll skip this slide, but important to remember that diagnosis with spirometry is a no-no in asthma. It has to be clinical diagnosis plus spirometry. However, risk assessment, FEV1 is important. The low FEV1 predicts the risk of exacerbations. It's important to monitor with spirometry at least annually, and adjusting treatment when the patient has uncontrolled symptoms. Again, a spirometry can be useful. What are the categories of asthma severity? So we'll talk about this again in a bit, but mild asthma, moderate asthma, and severe asthma. So when we talk about GINA 1 and 2, that's mild asthma. Moderate is GINA step 3, and severe asthma is GINA step 4 and 5. This thinking is changing. We now feel GINA 5 is the only category which is severe asthma. But as of now, for our understanding, it's better to think 1 and 2 is mild disease, 3 is moderate disease, 4 and 5 is severe disease. So this is the algorithm that we follow. GINA follows, asks you to follow, watching patient use their inhaler and discussing adherence and barriers to the use. This is what we have discussed at length today. Confirming the diagnosis of asthma, and we've discussed this too. Remove potential risk factors, assess and manage comorbidities. This is something that we have discussed. And then consider stepping up and stepping down, which we will discuss in a minute, and referral to a specialist clinic. So not all patients with asthma need to be seen by myself or Susmita, this is a disease that should be treated in primary care or treated by our physician colleagues. However, it's GINA 4 and 5 where a referral to a specialist clinic becomes important. So we then spend the next 5 or 7 minutes talking about the global strategy for asthma management and prevention. So this is the management bit, which would be of interest to all of you. And what I've done here is to tell you what's changed between GINA 2018 and GINA 2019 and 20. And I start off, this no talk that's going to be complete just now without a mention of COVID. So I'll talk about COVID in the perspective of asthma. So if your patient has asthma, you are actually protected against having COVID. This protection is partial. However, if you do happen to get the disease, so if you have asthma and get the disease, then your morbidity with COVID is going to be greater. Why do I say that asthma patients are protected from having COVID, even if it's to a small extent? It's because of the use of inhaled corticosteroids. So inhaled corticosteroids help to control asthma, but equally have an antiviral effect on the upper airway and result in reduction of colonization of the coronavirus in the upper airway. This has been shown in a recent study called the STOIC study, which
there seems to be a technical disturbance. Dr. Samajdar, are you there?
Yeah, I am there. There is some technical glitch, I think, from Dr. Roychowdhury's side. So let me contact.
Let's see if we have any discussion in any messages in the chat box that we can take up in between. Dr. Tripathi, are you there?
Yeah, I'm there. Okay, I was actually muted. So by the time I think somebody can make a call to Dr. Roychowdhury. Dr. Shambo, would you call Dr. Roychowdhury?
I think Dr.
Yes, sir,
Samajdar
I'm calling. I'm calling.
Okay. So meanwhile, if Dr. Susmita is there is a question here regarding the S2S overlap, asthma and COPD overlap. What is the magnitude of the problem in India? Dr. Susmita, if you can say a few words about that.
Definitely. So what do you call it? ACOS, asthma COPD overlap syndrome, has a clear-cut diagnosis elsewhere, but in India, it is very difficult to say if somebody is chronic asthma, which has become fixed airflow obstruction, versus COPD with the asthma phenotype. Because in India, lots of people have symptoms for a very, very long time, and they tend to develop fixed airflow obstruction over a period of time for want of taking proper inhalers, etc. So if the pulmonary function test shows that there is at least 200 mils of difference, you would treat it as asthma. Whereas if there is no, history doesn't give any history of, sorry, I think Raja is back, of giving asthma, a history of asthma in the past, and there is no seasonal variation or eosinophilic variant, then you would treat it only with bronchodilators. That is a difference.
Yeah, Dr. Dhar, in your absence, we are discussing about that overlap, asthma,
Absolutely.
COPD overlap.
Absolutely.
Okay, now you are
I'm very
back.
sorry.
You can go ahead with your. Okay.
Can is the other slides visible again, and can you hear me loud and clear?
No, the slide is not visible. You have to, I think, share the screen again.
Sure. 1 second. Visible now?
Yes, sir. Yes, sir. It is visible.
Okay. So talking about COVID and asthma, I'm sorry, guys, I lost connectivity for some reason. So I'll start again. So I think the last thing you heard me talking about was the role of inhaled corticosteroids in asthma and COVID. Is that right, Dr. Shambo? Is that the last thing you guys heard when I got disconnected, or was it even before that?
Yeah. Yes, sir. This was the area. Yeah.
Okay. So carry home message about that bit is inhaled corticosteroid is good in patients with COVID. If you have asthma, please do not discontinue inhaled corticosteroid. You shouldn't do that even without having COVID. However, COVID, there's now good evidence to show that mild disease, inhaled corticosteroids is good for you. And there's the STOIC trial with budesonide, which shows that. I was talking about the written action plan of asthma, and while it sounds trivial, this is something that we often falter on. So this is giving your patient a written plan of what to do when their symptoms increase. And you can base it on the 4 questions, the GINA assessment questionnaire that I spoke about a little while ago, with the 4 questions about daytime symptoms, nighttime symptoms, missing work, and the use of rescue inhalers. So based on that, you ask them to increase their controller and reliever medication, give them a short course of oral steroids if the symptoms become truly uncontrolled or the patient has an exacerbation, give them a plan as to when they need to seek medical help and need to come into hospital. And there are other bits in GINA, which I would ask you to read through, which talks in greater detail about the GINA action plan. And in COVID, there's a lot of talk about nebulization. I think the jury is still about of whether to nebulize or not to nebulize. However, in your wards where you have COVID or during the pandemic, do not nebulize within the hospital. Your inhaler and spacer is as good, and there is robust evidence and trials to show that. At home, if you're used to nebulizing for a long time and your disease is controlled only on the nebulizer, in that case, you continue nebulizing in an empty room, which is well ventilated, so the aerosol droplets can go outside. So avoid nebulization is the carry home message. So we spoke about avoiding spirometry during the pandemic, and the reason and the fact that in asthma, you don't need a spirometry compulsorily to make a diagnosis of asthma. And the fact that, like everything else, you need to follow strict infection control procedures if there are any aerosol generating procedures in asthma. So let me now talk about the most crucial part, which is about the key changes in asthma management in 2019 and 2020. I know there's a lot of physicians, pharmacologists who are a part of the audience today. So I'll spend a little bit of time taking you through the step up and step down management of asthma. I want you to see the top bit where my cursor is now. So the first thing you do in asthma management is to assess. So history plus spirometry or pleak flow measurement gives you a confirmation of the diagnosis. Then you look at triggers. You look at comorbidities. You look at inhaler technique and adherence. And that's your assessment. Then the patient comes back to you first at the end of 2 to 4 weeks and then at 3 months, and you adjust treatment based on the response that these patients have had. And then you review the response maybe at 3 months and then again at 6 months and a year. And this looks at symptoms, exacerbations, side effects of the drug, a repeat lung function, and the patient satisfaction which the treatment that you have given gives to the patient. So that's how you assess, adjust, and review for response. Then the medications. And you can see the medications are on a stepwise manner from step 1 to step 5. You have to have a preferred controller and you have to have a preferred reliever. So you see on the top, the preferred controller, and then you have a preferred reliever. And that's how this stepwise management has been designed. The GINA guidance has changed over the last 1.5 years in that you're starting early inhaled corticosteroids in these patients. And the carry home message for all of you is that the patient, irrespective of whichever step of asthma, should not have a puff of inhaler without having an inhaled corticosteroid. The reason is obvious. We said that inhaled corticosteroid is the drug which prevents remodeling of the airway and maintains the reversibility, the elasticity, the compliance of the airway. And hence that's why starting the inhaled corticosteroid early is important. There's a couple of big trials which looked at as and when needed ICS and formoterol. So formoterol and budesonide in low dose. So you use the drug SOS on an as and when required basis rather than using salbutamol or levosalbutamol SOS. And it's been found doing that can actually reduce exacerbations as much as using regular inhalation can. And it does much better than using SOS levosalbutamol. So that's step 1. Step 2 is a low dose inhaled corticosteroid. That's first choice. Or it's an inhaled corticosteroid plus formoterol, again, as an SOS basis. In my book, the second option is lower down as compared to the first, but these two compare in various studies that's been done. Also in step 2 is using a leukotriene receptor antagonist. So in our country, that's Montelukast. So you can use Montelukast on an SOS basis. Not on an SOS basis, but on a regular basis. When you use Montelukast on a regular basis, you also need to remember to stop the drug when the disease is well controlled. The drug works better in patients who have concomitant allergic rhinitis and asthma. Step 3 is a maintenance dose of ICS and LABA, so a low dose ICS plus a LABA. Step 4 is a higher dose of ICS plus a LABA. And then in step 5, you have various options, including biologic therapy. Where do you start? Should all patients be started on step 1? And obviously not. It depends on what sort of symptoms your patient has. And this is the box that's in GINA, which tells you the various steps. And I'll come back to this in a moment. So these are the stepwise symptoms which tell you which step to start at. So if the symptoms are less than twice a month, you start at step 1. If the symptoms are twice a month or more, but less than daily, then you start at step 2. If the symptoms are most days or waking with asthma once a week, then you start at step 3. If the symptoms are most day or waking with asthma once a week or more and with low lung function, you start at step 4. And then if you have uncontrolled symptom, you remember the questionnaire. So if the score is 3 or 4 on that GINA assessment questionnaire, you start on step 5. So that tells you how it's a sort of ballpark understanding of where to start and what to do. I'll skip this because we have discussed this already. But you remember now, ICS LABA is the inhaler that you start off with. You start it as an SOS inhaler. The best choice seems to be formoterol and budesonide. You then go to a maintenance dose of an ICS plus a LABA. You could add in a Montelukast at a later stage. Step 3 is when you increase the dose of the ICS plus the LABA, and then you add in various medications like the tiotropium, maximum dose of inhaled corticosteroid, or the biologics. Skip the one in case of children. What's the maximum daily dose of ICS plus LABA when you're using it on SOS basis? And I want you to look at the bottom on there. So the maximum recommended dose in a day is 72 micrograms of formoterol, which is 12 inhalations of budesonide formoterol turbohaler at 200 plus by 6 microgram. Beclomethasone plus formoterol is another inhaler that can be used on an SOS basis. And again, there's a maximum dose that GINA recommends for that drug. You've discussed assessment of symptom control. This remains across all GINA guidelines from 2008. And these are the various low, medium, and high inhaled corticosteroid in children 5 years and younger. I have put this slide up because there's a lot of concerns about children and the use of inhaled corticosteroids. And this chart tells you about various inhaled corticosteroid and what the total daily dose should be in these individuals. And please look up GINA and follow this chart if you want to. There's this black box warning that it's coming with Montelukast. FDA has said that there are some serious mental health side effects for asthma and allergy drug Montelukast, and they advise restricting its use in allergic rhinitis. This is something that I have taken on board in my clinical practice, in that even if I need Montelukast, I would stop it after a period of time, which is sometime between 6 weeks to 3 months when the disease is better controlled. And I would implore all of you to do the same in your clinical practice. So these are the goals of asthma management. I'll finish in the next couple of minutes because I think I've run out of time. So goals of asthma management are symptom control, risk reduction, and achieving these goals requires a partnership between you, so the physician, and the patient. And very important, something to carry home with you about patient communication, you need to ask your patient about their goals regarding asthma. So the patient might tell you their goal in life is to take their grandchildren for a walk, for instance. It might be to climb one flight of stairs easily, for instance. And hence the endpoint that your patient wants to achieve is important. And this is something should be set in the prescription when you start treatment for your patient with asthma. Good communication, we have said again and again, is important and is essential as a strategy in treating asthma well. And consider your own healthcare system, our healthcare system, the availability of medication, and personal and cultural preferences, which is very, very important in India, where there's a lot of taboo, both about the diagnosis of asthma, and also about the medications and the inhalers that are used in asthma management. I'll stop there and I'll happily take questions if there are any.
Thank you very much, sir. So, is there any, sir, Tripathi sir, are you there? So we'll take question now, or we can take questions later after Madam's session.
I would be happy, not a lot of questions. I would be happier to take a few questions now, because then I can go and sort of do a virtual word round again. But
Okay.
if there's a lot
So
of
there is one question asked by Dr. Madhusudan Singh. So what is psychogenic asthma, diagnosis and management?
So that's a very good question. And I did not touch on this. So it's nice of you to have asked this question. There isn't actually an entity called psychogenic asthma. However, the question is a good one, because breathlessness in general and asthma in particular results in a lot of anxiety. And anxiety results in a lot of hyperventilation and panic, and this aggravates breathlessness. So often patients would get into this vicious cycle of worsening asthma symptoms, a lot of anxiety, hyperventilation, increased breathlessness, worsening asthma. And you need to break this vicious cycle by talking to these patients, ensuring compliance and adherence, reassuring them, and often in the very significant cases, severe cases, you would need help from a psychologist and a psychiatric colleague in helping you to break this vicious cycle of asthma and hyperventilation, panic attacks, etc. There's a small cohort of people who don't have asthma at all and just have panic attacks. These are classically younger patients, sometimes women, sometimes medical professionals, and these people just hyperventilate. They do not have airway hyperreactivity, and that's another entity that needs to be recognized. But remember, before just thinking it's psychogenic, make sure that there's no underlying bronchial hyperreactivity, which is aggravating the symptoms of breathlessness.
Thank you, sir. So another question is device choice in asthma, asked by Dr. Somudra Gupta.
Sure. So, Shamudra, I think we have discussed this question even before. So thank you for asking this question. So there are two parts to this. Ideally, a device should be chosen with your patient. The patient should have a say in what device you give to them. There is often some degree of personal prejudice involved in the selection of an inhaler device. So for instance, for me, a lot of my patients, a significant proportion, and I know it's the same with Susmita. So a lot of people would actually, both of us would use a MDI with a spacer. That's related to the training we had in the UK, where this was one of the commonest inhalational devices used. However, the young patients would like something like a DPI, which they can carry in their pocket. Cost becomes a factor sometimes, and the one-time cost of a DPI is less than what you have for an MDI. So there's various factors associated, and I think the best thing is to always make sure that you take the decision in conjunction with the patient rather than doing it on an individual basis.
Thank you very much, sir. So I think there is no more question. So another
one more, Shambo,
yeah,
about
one important.
Yeah, sorry, go on, Shambo.
One important question that often asked in many sectors after that black box warning against Montelukast. So what is your comment on that? Montelukast and mental health.
So the most interesting, the most intriguing part was suicidal ideation, which led to this black box warning. There's a lot of problems. There's flight of ideas. There's MDP, so manic depressive psychosis has been described in some individuals, but the most important one is suicidal ideation, which happened in a small but definite percentage of patients on long-term Montelukast. I stress on the word long-term. So in patients with long-term Montelukast, and that's something that should be kept in mind. Again, important to say, it shouldn't stop you from prescribing the Montelukast. It's just to remember that once you prescribe the drug, at some point when the disease is well controlled, you need to take it off also.
Thank you, sir. So again, we are really thankful to you, sir, for giving us time from this during this so busy hours, and you are so much busy in your COVID patients, for dealing with your COVID patient. So thank you, sir. So now we'll move to our next session, and that is on perspectives in treatment of COPD and importance of adherence. So may I invite Dr. Susmita Roychowdhury, madam. Welcome you, madam. Now over to you.
Thank you, Dr. Shambo. So thank you once again for asking me to come and talk about something that most of us will be treating. And is it visible to everyone?
Yes, well visible, Susmita.
Okay. So I've been asked to talk about perspectives in treatment of COPD and treatment adherence. So I've tried to bring perspective in the Indian context. So let's just know a few facts about our own country and this disease, or this condition in particular. We know that India contributes quite significantly to mortality from COPD, which is surpassing malaria, TB even today. And the gap would get wider as the time goes in the near future. And I'll show you some data, which is why all of us need to know what we can do best for this significantly large section of patients. And multiple studies from 1994 to 2010 show increasing trends of COPD morbidity and mortality. A couple of studies in the Indian context. The first one was in 2012 in the Journal of Thoracic Disease, where they talked about COPD in India. Is it an iceberg or volcano? Leading on to it in 2018, this burden of chronic obstructive pulmonary disease in India, the status, practices and preventions was again discussed by these set of people from Bangladesh, actually, who wanted to talk about our country. And despite this being one of the major diseases, and despite most inhalational drugs available in our country, one of the problems is that there's extremely poor adherence to treatment guidelines. There is a lot of disparity between urban centers compared to the rural counterparts in treating, diagnosing, and managing and following up patients of COPD. And above all, something that in the COVID era, we have come to realize even more, that the national GDP spend on a chronic disease is significantly low, less than 1.5%. When we talk about prevalence of COPD, some of the studies that we have shown that this one in 2001 from the PGI Chandigarh group showed that in the Indian males, approximately 3 to 8% of Indian males have a prevalence of COPD amongst them, much lesser of 4.5 in the Indian females. And this multicentric study showed that it was overall on an average about 4.1%. This was from 2001 to 2006. So you can see the gap. So approximately about 5% in males to 3% in females. This is again the same group. Along with that, a few more from other places. And what they showed was not only smoking was a factor, but in India, cooking fuel exposure documented from 2% using LPG to around 5%, those who were using kerosene and biomass fuels and firewood. And India will have, they projected that India will have about 5 to 6 times the population of entire New Zealand. New Zealand, if you take the entire population of New Zealand, 5 to 6 times of that in India alone will have COPD. And that is just the tip of the iceberg, because we really don't know what the situation is. And it has grown along with asthma, as Raja said. This has grown to nearly about 30% from 2006 to 2016. If you look at the India's map in 1990 and then in 2016, you can see nearly all of India is affected with COPD, and in bright red, which means more than 4,000 people in every 1 lakh population has COPD. So the overall prevalence, if we were to talk about MCQ numbers, it is the prevalence among studies has ranged from 2 to 22% in men and about 1.2 to 19% in studies among women in different population-based studies in India. This contributes to a significant amount of economic burden, and the burden of COPD is more than asthma, even when it is underdiagnosed, even when it is so underdiagnosed in COPD. Now, when we talk about management of COPD, let's just quickly recapitulate that the etiology of COPD that we talk about is smoking and pollutants, and also I'll talk about the Indian etiological factors, lead to impaired lung growth, accelerated decline of lung function, continued lung injury, and continued systemic inflammation and lung inflammation, which lead to small airway disorders and abnormalities to begin with, gradually can progress to emphysema, recurrent infections, chronic bronchitic type of phenotype, and systemic effects arising from that, which can manifest as in airflow limitation, causing breathlessness all the time, which is persistent and is irreversible. And the clinical manifestations are symptoms, and we look at how many exacerbations the patient is having and the comorbidities. All these clinical manifestations together are actually going to determine how well your patient with COPD is going to live and what their longevity is going to look like. So we will not just look at the disease, but all the other associated problems with it. Now, if we look at all the things that can cause COPD, we know that it is air pollution, which can be outdoor air pollution or household air pollution. Household air pollution in India is significantly high. Smoking, obviously, worldwide. Occupational risk, certain occupations where there's significant amount of particulate matter generation, ambient ozone pollution, and secondhand smoke or passive smoking, which is an important factor in rural India. So when there's exposure to particles, the risk factor for COPD is smoking, which is 80 to 90% of all COPD cases. In India, 18 to 19% of all Indians smoke, and it accounts for only 14% of COPD deaths, suggesting that non-smoking risk factors are the major contributors to COPD in India. And you all would have seen pictures like this a lot. All of us in India have seen on a daily basis a household very near to us who are still using biomass fuel. And it's not just this elderly lady who's being exposed to it. These are this young lung which has been exposed at a very, very young age and is going to continue to be affected with continued lung injury and systemic inflammation throughout her lifetime. Indoor air pollution is significantly high. And as Raja said, the CRF Institute in Pune, they did a COPD questionnaire survey, and they found that non-smoker females with COPD constituted 65% of all female COPD patients defined by the above criteria in their population that they saw. Socioeconomic factor obviously contributes to significant amount of biomass fuel use in our country, and poverty is consistently associated with airflow obstruction, which is an indirect way of saying that this population uses biomass fuel. And they are also, because of close proximity to each other, they have significant infections continuously. Also, severe childhood respiratory infections, tuberculosis, etc., patients are at increased risk of COPD. When we talk about India and COPD, TOPD or post-TB COPD is a significant risk factor, and anybody who has had pulmonary tuberculosis runs a relative risk of 26% at 5 years post-anti-TB treatment, which increases to 41% after 10 years post-antitubercular treatment if they had significant pulmonary TB. So longer the duration post-completion of anti-TB treatment, longer is the chance of developing at least spirometry positive COPD, and most of these patients will have small airflow limitation. Post-TB COPD may increasingly be accepted as a separate phenotype, and as I say this, most of us do accept TOPD as a separate phenotype of COPD. Now, how do we diagnose when the patient comes? Raja said in asthma, the diagnosis is mainly clinical. You may use pulmonary function testing or spirometry to show reversibility. In COPD, the symptoms of shortness of breath, chronic cough, or sputum production mean nothing until you have shown a spirometric evidence of number one, obstructive airflow obstruction, and number two, irreversibility or less than partial reversibility. And the risk factors are present in these patients. So symptoms, risk factors confirmed by spirometry to establish the diagnosis. So in the past few years, combined assessment has become popular. We will recapitulate what combined assessment is about, and it actually helps you. And I'll show you very simply why we should not just go by spirometric indices, but combined assessment of a patient to diagnose their severity of COPD, because the awareness is still much low. It is underutilized because it requires a few things to be looked at. And most of us are have so much time constraint with so many people sitting outside your OPD that symptom scores, etc., is not done. This also tells you The reason combined assessment has to be done is because it is a complete assessment. What does it include? Spirometric severity. Second is symptoms, how symptomatic your patient is, by looking at the dyspnea scoring by either the MRC or the CAT assessment. And number 3, taking the history of exacerbations in the past 1 year for that patient. So this is a very simple one. So first of all, patient does spirometry. You show that the patient has obstructive airways disease, which is irreversible. Now you look at how bad is the airflow limitation. When we say how bad is the airflow limitation, you all remember that we used to talk about gold stage 1, gold stage 2, gold stage 3, and gold stage 4. So FEV1 80% or more with FEV1 FVC ratio of less than 0.7 is gold stage 1, which is mild COPD. Gold stage 2, where FEV1 is 50 to 79%, which is moderate COPD. Gold 3 is 30 to 49 of FEV1, which is severe COPD, and less than 30% of FEV1 is very severe COPD. This is what we knew until combined assessment came. So combined assessment, what does it extra add? You look at what is the symptom of the patient and what are the risk of exacerbations. Because multiple studies have now shown that more the exacerbation, worse the prognosis of the patient with COPD. So you must know how many exacerbations the patient has had. So if the patient has 0 or 1 exacerbations in the past year, not leading to hospital admission, then they fall in category A or B. And if they have more than 2 exacerbations or more than 1 leading to hospital admission, they fall in category C or D. Symptoms wise, if the patient has a MRC category of 0 to 1, which is mild exertional symptoms, they will fall either in category A or C. If they have MRC criteria of 2 or more, which means they are quite symptomatic, they will either be in B or D. So if a patient has less symptoms and less exacerbations, they fall in A. If the patient has less symptoms but more exacerbations, they fall in C. If the patient has more symptoms but less exacerbations, they fall in B. If they have more symptoms and more exacerbations, they fall in D. So quite logically, the category D is the one that you have to look out for. They are the severest form of your COPD that are present. So let me make it simple by an example. If you have 2 patients, both the patients have FEV1 of less than 30% of predicted, have a CAT score of 18, and one has no exacerbation in the past year, and the other has 3 exacerbations in the past year. Okay. So previously, they would all be severe, very severe COPD because FEV1 is 30%. But what happens with combined assessment? The subject who has 3 exacerbations will be gold grade 4 and group D, right? So the one that has more exacerbations has more severe COPD. So that is the difference that has come in when you attach combined assessment of COPD in these patients. And you can tell your patient even better as to what their chances of coming back to hospital are depending on the combined assessment. So the management algorithm that we have for these patients of COPD is, if they are in group A, which basically means less symptoms, less severity, least symptoms, least severity, you just give them a bronchodilator. When you say a bronchodilator, which one should you use? A short-acting bronchodilator, which can be a SABA or a SAMA, which means either atropine-related bronchodilator or the short-acting beta-agonist bronchodilator, like, for example, levosalbutamol. Group B patient, they are quite symptomatic because their MRC criteria and CAT is more than 10, but they have less exacerbations. So the idea of treating a COPD patient is bronchodilation, 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 because you are doing symptomatic management. Whereas in asthma, you have to control inflammation, which is why inhaled corticosteroids are the mainstay of therapy. In COPD, however, bronchodilation is the mainstay of therapy, where you will use inhaled corticosteroids. I'll come to it in a minute. So group B will have LABA or a LAMA. So you either start with a, for example, tiotropium, or you can start with a LABA, But usually it is the tiotropium alone that is quite comfortable for a patient because it's a once a day treatment that you can give them. Group C is more is the patient who has less symptoms, but they are at increased risk of exacerbations. So here again, you start with a LAMA, and if they are still symptomatic, you can add a LABA to the patient. Group D, however, are patients who are highly symptomatic and at increased risk of exacerbations. They will always be on a LAMA-LABA medication, for example, glycopyrronium and indacaterol, or it can be formoterol and tiotropium, depending on which one your patient finds best. I have found that most of my patients do very well irrespective of their FEV1 level if they are on indacaterol, glycopyrronium, single day DPI use, because it's once a day and it actually makes them feel so much better. It doesn't make them feel as if they are sticking to their medication and they need to carry it along with them. It's a long-acting medication and most of them do very well. However, if these patients have increased number of infections, if they have increased number of exacerbations, or if they have a asthma phenotype, or if their sputum eosinophils is more than 5%, then you should add inhaled corticosteroids to it. So they can have a triple combination of a LAMA plus LABA, or an inhaled corticosteroid and LABA, or a triple device, which is LAMA, LABA, and ICS combination together. So each patient will have to be individualized. There is no one magic bullet for treatment of your patients here, because it is symptomatic management, and whichever combination gives your patient best symptomatic management, please continue with that. So the key points as per GOLD guidelines to remember for bronchodilators is that LABAs and LAMAs are preferred over short-acting agents in patients, except if they have occasional dyspnea. Patients may be started on a single long-acting bronchodilator therapy or dual long-acting bronchodilator therapy, and then you look at the bronchodilator treatment, which can be escalated if your patient is still symptomatic. And inhaled bronchodilators are always recommended over oral bronchodilators. Please remember, theophylline is not recommended unless their other long-term treatment bronchodilators are unavailable or unaffordable. In certain rural areas, you might need to use that, but not as a primary treatment. Regarding anti-inflammatory agents, monotherapy inhaled corticosteroid is not recommended in COPD. Long-term treatment with inhaled corticosteroids may be considered in association with LABA in patients who have recurrent exacerbations in spite of using appropriate long-acting bronchodilators. Oral corticosteroids with long-term therapy with them is not recommended. And in patients who have severe or very severe airflow obstruction or limitation with a chronic bronchitis phenotype and recurrent exacerbations, you may add PDE4 inhibitors such as roflumilast with long-acting bronchodilators with or without inhaled corticosteroid. Please remember, never give roflumilast along with theophylline together because they have significant amount of side effects together. Preferentially, but not only in the former smokers with exacerbation, if they're despite appropriate therapy, they are having recurrent exacerbations, macrolides such as azithromycin can be considered 500 milligrams 3 times a week for 6 weeks to 3 months, depending on how much your patient is exacerbating. Give them for 6 weeks and look at them again. Statin therapy, in the meantime, had gathered a lot of clout, but it is not recommended for prevention of exacerbations. And antioxidant mucolytics are recommended only in selective patients with COPD who have bronchiectasis associated with them or who have thick tenacious mucus secretion for a period of 7 to 14 days, depending upon how symptomatic they are. So the entire idea is that you look at these patients and you start the treatment and you bring them back after 4 to 6 weeks and you see if the response to initial treatment is appropriate, you maintain it and follow them up every 4 to 6 months. If not, you consider which is the predominant treatable trait to target. Is it dyspnea or is it exacerbations? And then use the pathway that has been given. This is nicely available on the GOLD guideline website. If you want, I can always give you my slides. You assess the response, adjust, and then review again. So If the patient is dyspneic, you start with a LABA or LAMA. If they're still dyspneic, you give them the combination. If they're having recurrent infections, then you add an inhaled corticosteroid. And then finally, LABA, LAMA, ICS. If they are having exacerbations, then again, it's the same thing as I have discussed. And if they have chronic bronchitis and severe exacerbations with FEV1 less than 50%, you can add roflumilast for exacerbators. And in former smokers, you may consider azithromycin therapy. Now, some patients, as Shamudruda asked about the ACOS variant and if blood eosinophil levels are high in certain patients, it is important to see these patients who are having recurrent exacerbations. The threshold of blood eosinophil count of more than 300 cells per microliter identifies the top of the continuous relationship between eosinophils and inhaled corticosteroids. And this is the subset of COPD patients where you would like to add inhaled corticosteroids. Blood eosinophil counts, however, of less than 100 cells per microliter can be used to predict a low likelihood of a beneficial inhaled corticosteroid response. So if it is less than 100, it is unlikely to be useful or helpful. So let's talk about the other pharmacological treatments. Some very, very few people who will have hereditary alpha-1 antitrypsin deficiency need to be recognized. These are younger people developing emphysema with a history of hereditary emphysema in their family. Antitussives, the gold guidelines say, should not be recommended. The drugs approved for primary pulmonary hypertension are not recommended for patients with COPD and pulmonary hypertension because hypoxia is the driving force and long-term oxygen therapy is what should be prescribed rather than primary pulmonary hypertension medications. Low-dose, long-acting oral and parenteral opioids can be considered in very severely dyspneic patients, end-stage COPD patients with severe disease. And non-pharmacological management, which must be always talked about every time the patient comes to you. If they are a smoker, talk about quitting, give them smoking cessation advice, including pharmacological treatment only in motivated people who are going to be following up with you. And recommend physical activity for all of them. And depending upon local guidelines, please give them advice regarding flu vaccination and pneumococcal vaccination, and I will talk to you about it. So in patients of category A, group A, smoking cessation each time, group B, smoking cessation and pulmonary rehabilitation must start as soon as possible. It can be home-based, it can be center-based, but they need to be active. They need to maintain their nutrition because it is a systemic disease and it can continue to make the patient very weak. So review, adjust and assess and adjust treatment at every time these patients come back to you. And vaccination, influenza is recommended for all the patients. Pneumococcal vaccination, if somebody is vaccine naive, then you should give them PCV13 first and a year later the polysaccharide vaccine. The PCV13 or the conjugate vaccine is only once in a lifetime, and the polysaccharide vaccine should be repeated every 5 years until they are the age of 75. Hypoxia and COPD, if the patient has severe resting hypoxia, long-term oxygen therapy is indicated, and resting oxygenation at sea level does not exclude the development of severe hypoxemia when traveling by air. So they should always have their oxygen levels checked for flights, long flights before they go if they have COPD. Those with chronic hypercapnia and a history of hospitalization for acute respiratory failure, long-term non-invasive ventilation may be considered. And if there's exacerbations, most of them are secondary to infections. Find out if it is bacterial or viral. And the goal of treatment is to minimize the impact of current episode and prevent further exacerbations. When antibiotics are indicated, give at least for 7 days. And short-acting beta-2 agonists with or without anticholinergics and a short course of systemic steroids is given. Nebulized bronchodilators may be necessary to begin with, which can be shifted to a MDI with a spacer, which works much the same, especially in the COVID era, to avoid increased aerosol generation. And if respiratory failure, then non-invasive ventilation. If respiratory acidosis persists, may even require mechanical ventilation. Always treat comorbidities, look for comorbidities because they are usually present in COPD patients, always, almost always. The common ones are gastroesophageal reflux disease, cardiovascular disease, lung cancer, osteoporosis, depression and anxiety, and malnutrition are the common ones associated. And as I said, this is again available. I'm reiterating it over and over again. The management of COPD is diagnosis, initial assessment, initial management, review, adjust, assess, and continue. So you have to give the patients that amount of time, because adherence to therapy is very important. Just as in diabetes, just as in hypertension, it is extremely important that we keep stressing that the patients must adhere to treatment. Supportive treatment in India, the ones that are available are long-term oxygen and domiciliary NIV, and assisted early discharges from hospital. This is still wanting. Palliative and end-of-life care support is really, really important, but hospice care is not available in most parts of India. And lung transplant and surgical interventional therapy are not in the purview of the discussion today, so I will leave that. This is a very important penultimate slide that I have, that despite the knowledge, the Indian physician's dilemma is deciding to give the appropriate pharmaceutical therapy. This is something we have discussed, and each time we discuss, it becomes even more important. Explaining the diagnosis to the patient and explaining why it is important to adhere to treatment. Make my patient give up smoking is another very important thing that we all struggle with. And unless the patient himself is motivated, when a patient has a heart attack, they immediately stop smoking. But if you give them a diagnosis of COPD, they will not continue to stop smoking unless they have been admitted in hospital and have been in the intensive care unit. And make my patients understand that their medication has to be taken on a regular basis. Most of us struggle, as you will see here. And that is very, very important. And selecting the correct device is important, because adherence improves if it is the right patient and the right device. If it is a patient with who has rheumatoid arthritis and you give them an MDI and spacer, they will not be able to use it. Whereas if it is a patient who has very severe COPD and doesn't have enough breath to pull, and you give them a DPI, it won't be there. So please spend time choosing the right device for the right patient. And what is the right device? The device is right, which one the patient chooses and is able to perform in front of you correctly. Please ensure technique, therefore, and initial early follow-up to ascertain inhaler compliance. Sometimes dosimeter related inhalers are much easier to see, because you can police whether they have been using it properly or not. Counsel them each visit, and at least 6 months to annual spirometry to see if there is any decline. Vaccinations, as we have discussed already. And prevention in India, biomass fuel is the leading cause, and we need to try and have multifaceted long-term strategy to tackle all the above to reduce the risk of preventable COPD. And once diagnosed, reiteration and adherence to treatment is absolutely essential. So finally, in conclusion, COPD is the second leading cause of death in India just now, and very soon it will be the first one. Air pollution is fast overtaking environmental tobacco smoking as a major risk. And in India, biomass fuel is the main one. Combined assessment and diagnosis of COPD needs to be incorporated in our day-to-day practice. And tailor-made symptom-based optimization of inhaled bronchodilator therapy and stepwise management will reduce COPD morbidity. And vaccinations definitely need to be made integral to COPD management. Thank you very much.
Thank you, madam. Thank you very much. So may I request today's chairperson, sir, Professor Santanu Kumar Tripathi, to make some comments, and then we'll go for some questions.
Yes. Thank you very much, Dr. Roychowdhury. I don't know whether Dr. Rajadhar is still there. It was wonderfully, the two aspects, the asthma and COPD, both of them are very well covered, and particularly also highlighting the focus area of adherence, importance of adherence has also been mentioned. This is a very, very recent update on both these two areas, and we are happy, we are really privileged to have two stalwarts like both of you who have made this vivid presentation. And I sincerely believe that all the participants who are listening to these presentations today, they have been immensely benefited. And I must thank you all. But then there might be a few questions if in the chat box, if Dr. Shambo, if you can read out those questions, and then we can come back again other discussions.
Yes, sir. So Dr. Somudra Gupta had asked that pulmonary rehabilitation and lung volume reduction surgery with COPD and long-term oxygen therapy target and home oxygen concentrators and BiPAP utilization. So may I ask Dr.
Quite a lot of
Roychowdhury
questions
to
in
comment here.
one whole slide in a question. Shomudroda has come to kindly nicely test us. That's fine. But so long-term oxygen therapy has very clear criteria. And if you go through the long-term oxygen therapy criteria, if somebody has resting saturations of less than 92, they should also have an arterial blood gas done, and they should have an echocardiogram done. So 3 things you need to look at. What is the resting saturation? What is the PO2 level of the patient? And what is the pulmonary artery pressure of the patient? So an echocardiogram, an ABG, and what is the saturation of the patient? These 3, if you've done, if you look at the criteria, rather than me mumbling it out, if they match it, then, and the patient has severe COPD, then they should be prescribed long-term oxygen therapy. With regards to lung volume reduction surgery neither was before and even now a major part, but there are certain patients who have significant bullous lung disease, which causes significant amount of deterioration in their day-to-day life. And those would be patients that would be considered following a proper CT assessment and a spirometer and a full pulmonary function testing assessment to see whether they would benefit from lung volume reduction surgery. However, there are very few thoracic surgeons at the moment as well. Previously, there were fewer, but now there are more, but still not that many centers and not that many dedicated thoracic surgeons to do that. But centers that do that should be promoting these surgeries for the patients. What was the other question?
Rehab.
Long-term oxygen therapy.
Rehab. Long-term oxygen therapy, Bullam. And rehab, pulmonary rehabilitation for everyone in group B to D. Group A patients, because they are not that symptomatic, they should always be encouraged to be active, but pulmonary rehabilitation should be definitely encouraged in all the patients of COPD in category B, C, and D. And this, obviously, again, you can say in COVID era, for patients to keep coming back to hospital to do it is not going to be an easy task. But, being active, maintaining their nutrition, ensuring that their mental functions are okay, and the kind of support that they need, and maybe virtual platforms of pulmonary rehabilitation can be built. Having said that, we work in bigger hospitals and we are not able to do it on a regular basis at all. But that is definitely should be encouraged in whatever way possible. Ideally, they should be able to dedicate 30 minutes for 5 days a week for 6 weeks at least, and that has been shown to improve the functional capacity of most patients with COPD, irrespective of how breathless they are to begin with.
I think it has not been really very so far as the pulmonary rehabilitation. We find there is not enough takers, and neither it is that way practiced to a great extent. Even way.
Absolutely.
Yeah.
So,
I was
Dr.
having
Tripathi,
some...
can I
please.
sort of add something in response to what you said? So I think in some ways, COVID has actually changed our life for the better. And I think pulmonary rehabilitation is one of them. So of late, there's been a lot of trials which have compared institution-based rehab with home rehabilitation. And then in the COVID era, there is virtual supervision of home rehab. So
Right.
I think we're learning how to do home rehab. And once we manage to shift rehab from hospitals and outpatient clinics to homes, I think the number of takers for home rehab would be far greater than what it is for institutional rehab. And that's something for which the evidence is still evolving.
You are very right. I think we should take this opportunity to have a telemedicine-based home rehab, and we can try to popularize this also. This is the opportunity we can try to do this. Because people are relatively getting more and more adapted to this telemedicine consultations and telemedicine advices. So I think it is an opportunity now. I was having another question, and that is regarding somebody who is, say, for instance, suffering from an old COPD patient and who has contracted COVID infection.
after he recovers, then what do you think? What would be the impact of, or what is the, whether the probability of response to the treatment prior to COVID vis-a-vis after COVID, how situation is changing, Dr. Roychowdhury?
So that's a very nice question, Dr. Tripathi. We have seen even in patients who don't have COPD but have had moderate to severe COVID actually end up, when they come back to your clinic and 6 weeks later you do a spirometry, most of them will have small airflow obstruction. And depending on how bad, if they were in ARDS or if they had much more involvement, so they have significant amount of small airflow obstruction, also medium size airways involved. So if they have, and they are symptomatic, but these patients gradually respond to steroid therapy in their symptoms. But when they come back, even after 6 months, their pulmonary function is poorer. But most patients, because we don't have their pulmonary function from before, we wouldn't know. But I have noticed that in my COPD patients who had COVID, their symptoms initially decline, but then stabilize. And it hasn't really changed much, except that I have had to give them more bronchodilators post-COVID. And they have taken nearly about 3-4 months to actually stabilize. I don't know what Raja's...
Yeah, that leads me to another question, related question that I had put up in the chat box, that should elderly patient who had a smooth, uneventful recovery from COVID-19, are they at greater risk of developing COPD?
Yes, again, as I said, this is my observation as well. For patients, elderly people who have had the moderate to severe COPD, they definitely develop, they definitely develop small airflow obstruction and symptoms of COPD, and a lot of them actually benefit from giving them SABA or a SAMA initially, and some may even require a long-acting antimuscarinic agent when they come back 6 to 8 weeks later.
We'd also like to hear from Dr. Dhar, say for instance, your asthma patients who are otherwise better controlled, well controlled, and then get this infection, COVID infection, recover, and post-COVID, how they fare when they come back to you, Dr. Dhar.
So I'll broadly answer, sort of taking off from where Susmita finished. So, there's been some phenotyping of COVID now that we've had the disease for 14 months. There's been some phenotyping of COVID infections. And we have found that in about 80% of patients, the disease is mainly parenchymal disease. So the ground glass opacities that you see, the consolidation that you see on CT and we all score is parenchymal lung disease. In about 20% of cases, you seem to have predominantly airways disease. So this is akin to COPD being called as chronic bronchitis and emphysema phenotype. Similarly, COVID seems to have two phenotypes. One is parenchymal disease, which is the majority, and the minority is airways disease. If you look at airways disease, there's a very neat study which comes out of Oxford, Mona Baffadal's group, where they did exhaled nitric oxide on these patients who seem to have more of a cough. So cough correlating with airways and hence an exhaled nitric oxide in these patients. And they found that the mean pheno, looking at airway inflammation in these patients, exceeded 50, when the patients had active disease. So these were disposable pheno machines, which was used in 10, small number, but it was more a proof of concept study. And hence, airway inflammation was thought to be a big factor in patients with COVID who had more of a chronic cough. And it is thought that in these patients, if you combine and inhale budesonide with a bronchodilator, the way Susmita was describing a little while ago, you would probably get greater relief from the cough as compared to using an inhaled corticosteroid alone. Some of these patients in the long term, if you monitored them, they would develop airways obstruction. They could have asthma, they could have COPD, but they will have some degree of airways obstruction. But these patients respond well to inhaled corticosteroids and bronchodilators in the long term. And like the lung fibrosis you see in COVID, the airways obstruction also seems to resolve over a period of time, or at least improve if you use the ICS and LABA in the long term.
Yeah, we find a good number of patients, particularly elderly, that post-COVID, they tend to have a nagging kind of residual cough for quite a few weeks or months together. So both of you, I think, would opine that they should have a pulmonologist visit. Okay. I have another question to Dr. Roychowdhury, and that is childhood asthma. Although you have said that it's a chronic disease and it's a lifelong disease and there is no cure, but then we come across anecdotal reports of childhood asthma, and then as they grow older, or in the young adult, their symptoms gone off. So for say 5 or 6 years they were treated with asthma, but then they got into some kind of sports and some kind of athletic activity, and they are well off, and in their later life they never had any symptoms. What do you think? What is that actually? Was it asthma or misdiagnosed as asthma?
So I'll tell you, Shantanu. So this is a very intriguing question. I'll tell you why that is. So if you look at the natural history of asthma, people who have childhood onset asthma usually start off by having significant allergic rhinitis, then a little bit of dry cough, wheezing, exacerbations, some amount of breathlessness. And a majority of these patients in the post-adolescent period, early adulthood, would say that their asthma has gone away. And then again, in about 65, so 2/3 of patients, the symptoms seem to reappear in sort of in their late 20s, early 30s. And then when you measure their lung function, their airway is remodeled and they seem to have fixed airflow obstruction. In a third of patients, the asthma never comes back at all. And I think I rushed through my talk a little bit, which is why the audience missed that I said that if you manage asthma well in childhood, if the inhaled corticosteroids are continued long enough, ensuring that the patient is asymptomatic for a prolonged period of time, you can even have a cure for asthma. The symptoms, at least a third of patients would never come back. And I don't think symptoms not coming back actually points you against a diagnosis of asthma. It just means that the disease has been treated well, or the airway hyperreactivity has gone completely because of maybe environmental factors, because the treatment that's been given, or because of absence of triggers.
Great. Dr. Shambo, are there any questions, any more questions in the chat box or any member?
So, sir, we almost cover all the questions.
There was another question of Inos therapy in COPD.
I'm not sure what Samudruda means by Inos therapy. Actually, exhaled nitric oxide is not a therapy which is recommended for COPD as such. There have been trials, but it's never actually been substantiated. I spoke about exhaled nitric oxide in the diagnosis of asthma and about in COVID. I'm not sure whether Susmita, any clues about Inos therapy in COPD? Samudruda has asked that question. I've not really managed to answer it. Nitric oxide has been trialed in patients with COPD without much success. It's more used in pulmonary hypertension, where nitric oxide analogs have been used. I'm not very sure about its use in COPD.
You have to unmute yourself.
I think he's probably talking about the thing in nature that had come. It's all still experimental. It's about targeted therapy, but I don't think it is recommended therapy at the moment.
All right. If there are no more questions, Dr. Shambo, you can have some concluding remarks. And it was a very wonderful session. Both the two sessions were very, very educative, and all of us have enjoyed. There were good interactions also. I thank both of you profusely, Dr. Roychowdhury and Dr. Roychowdhury. And over to Dr. Shambo, please. Go ahead.
Yeah, thank you, sir. Thank you, Dr. Roychowdhury, sir, and Dr. Susmita Roychowdhury, madam, for giving us time. And it is really wonderful to listen from both of you. So we discussed about COPD and asthma and the importance of adherence. I just want to finish by the definition of adherence, which is very important, I guess. So what is adherence? It means the extent to which a person's behavior to take medication, following diet, and or executing lifestyle changes, as Dr. Susmita Roychowdhury, madam, emphasize on the cessation of smoking. So that also comes under adherence, and that corresponds with agreed recommendation from a healthcare provider. So there should be a agreed recommendations, and the patients should have a active partnership with the healthcare professionals regarding that particular recommendations. And to ensure adherence, there is one we can say synonym like simple. That means S for simplifying the regimen, I for imparting knowledge, specifically the informed prescribing, M for modify the patient's beliefs and behavior, P for provide communication and trust, L for leave the bias. So bias means we should not believe that while prescribing or just showing one time that patient will take inhaler always correctly. So we need to assess, reassess again and again. And finally, the E for evaluate the adherence. So it is our duty to see whether the patient is adherent or not. So thank you all for being with us. And we should remember this quote that drugs don't work in patients who don't take them. So with that, a very good night to all the respected delegates. May I request our Rohan, Mr. Rohan Tripathi, to say something, and we can conclude the event.
Thank you so much, Dr. Samajdar. I would like to take this opportunity to thank Dr. Dhar and Dr. Susmita Roychowdhury ma'am for giving us their valuable time this evening. I would also like to thank all our participants who took out time on their Sunday night, in spite of cricket and everything going on, a pandemic out there, but that they took out time to hear out the program. That it's quite an achievement on our part. So I am really thankful to everyone. Also, I would really like to mention that this is the fourth edition of a adherence awareness webinar series that we are having. We have already have 3 of these, and 4 and 8 more are yet to come. So it would be great for us if you all give us your blessings so that we can continue this journey towards successfully spreading awareness regarding medicinal adherence among all, and then continue with our journey forward. Thank you so much, everyone.
Good night.
Good night, everybody.